Dr. Craig Chaya will be our next speaker, who's going to deliver the keynote address on the topic and update on MIGS and its relevance in our practice. On to you, Doctor.
Okay, great. Just a moment to start from the beginning. Okay, well, I was going to say good morning to all of you, but it is quite early here still in Salt Lake City, Utah, but it's really a pleasure to be with all of you. I'm so grateful for the relationships I've made with some of you over the past several years. I look forward to the day when I'll be able to travel again and hopefully be able to be there in India live. And so today, the purpose of my talk is to really give you just a smattering update of all the different devices that are available and techniques that we have in the MIGS space. As you know, that this is a burgeoning field that's still relatively new in its infancy. I think many of us are excited about the opportunities that are available that we have for MIGS. And I think as way of moving into this, I have no financial disclosures, by the way, but I really wanted to give a tribute to my mentor. Many of you know Dr. Alan Crandall recently passed away almost 4 months ago and was a pillar in our institution at the Moran Eye Center. And one of the things that he told me as a fellow was that if you are doing the same thing you were doing last year, if you're doing the same thing that you're doing last year, you're not really advancing the field. And that wasn't really to be critical of our history of glaucoma surgery and the things that work well. We've already mentioned some things that we've been doing for many years, such as trabeculectomy and glaucoma drainage devices. But what his point was is to critically reevaluate yourself from year to year. And even trabeculectomy has room for improvement. And so I want to just remember him and remember this fantastic lesson that he gave us in terms of really pushing our field forward. So a little bit about the history of MIGS. As many of you know, the term was coined in 2009 by Dr. Ike Ahmed of Toronto, Canada, with these following 5 features that seem to be important. 1, an ab internal approach. This is changing though, I will say, but early on in MIGS, it was thought to be an ab internal approach with minimal trauma to the surrounding tissue to disrupt the normal physiology of the eye. It should be safe, efficacious in terms of its IOP lowering, and visual recovery should be rapid. So here's what we currently have in 2021 as all the different options that are available to us in the MIGS space. And as you can see, it is a large menu of options that we now currently have available. We have different otomy techniques that we'll go over. We have trabeculectomy bypass and scaffold devices. Viscodilation is a way of expanding Schlemm's canal to try to recruit more areas. As we know, trabecular or conventional outflow pathway is a segmental pathway. We don't get continuous flow throughout the entire Schlemm's canal. So by viscodilating the canal, we may be able to recruit more areas to help with conventional outflow. We have subconjunctival stents. We also have cyclo-ablative procedures. And finally, suprachoroidal shunts, we'll discuss briefly as well. So let me go over the first different array of techniques that we have available. And these are the different otomy techniques. And I like to categorize these as both non-excisional as well as excisional techniques. The non-excisional techniques have been recently popularized by Dr. Feldman and Dr. Grover from Dallas, Texas, with the GATT technique known as gonioscopy-assisted transluminal trabeculotomy. Now, we have been doing trabeculotomies for years, for decades in the history of glaucoma, but it wasn't until Dr. Grover and Dr. Feldman showed us that we could do this ab interno approach and really spare the conjunctival tissue for further glaucoma drainage surgery. We now have the Omni device. The Omni device is used to essentially enhance the outflow as well as to create an excision through the trabecular meshwork. This is a device that has a snare or catheter that allows this catheter to dilate the canal on its removal, and then the device can be rolled out again in order to create a trabeculotomy for either 180 degrees or 360 degrees. Now, in terms of excisional techniques, we have several. The first one that was ever FDA approved in this country was the trabectome. Trabectome uses an electrocautery unit in order to ablate the tissues. And this unit is right here. It's attached to an electrical surgical unit that has both irrigation and aspiration in order to remove the trabecular meshwork tissue. There's now been some iteration from Neomedics, the company that produces the trabectome, and that's this device right here, which is the TrabX device, which is very similar to the original trabectome in terms of its ability to also incorporate irrigation and aspiration, but uses a nice blade, dual blade technique similar to the Cahook dual blade in order to excise the trabecular meshwork. Many of you, I think, are familiar with the Cahook dual blade, which is this instrument here, in order to use a very polished instrument with a very delicate ramp in order to lift and excise the trabecular meshwork tissue. There is a technique that maybe some of you have heard about in meetings, but has not yet reached at least our country here in the United States, but I believe is CE marked in Europe. And that is ELT, which is using an excimer laser on a probe in order to create otomy holes in the trabecular meshwork. So it's using that excimer laser to precisely create these bypass holes through the trabecular meshwork. Later, I'll go a little bit into the bang technique, which is a bent needle goniectomy technique, which takes a 25 or 27 gauge needle to essentially create a dual blade style excisional tool. Now moving on to trabecular bypass scaffold devices, we have two main companies that are in this space, Glaukos and Ivantis. iStent was the original one that first was FDA approved in 2009 in this country, but we now have different iterations of the iStent that I'm showing you here. This one is the newest iteration of the iStent called the iStent W. And as you can see, it's again a titanium device to bypass the trabecular meshwork, and it has a lumen of approximately 80 microns, central inlet, as well as side outlets that promote flow through the trabecular meshwork, which are each 50 microns, and there are 4 included inside of the iStent. Now, what makes the iStent inject or iStent W different from the original iStent is that now in the packaging comes 2 loaded iStents on one device. The device is here. This is a trocar that's used to allow the devices to lay inside of the lumen of the injector. And now you can inject 2 iStents at the time of surgery with one device. In the future, there'll be an iStent Infinite, which will essentially look like the iStent W that I've shown you on this graph, but will now have 3 loaded iStents on the same injector in order to deliver the devices over a broader area to recruit more areas of flow. The current device that we have that is a microshunt as well as a scaffolding device is the Hydrus microshunt, pictured here, made out of nitinol. The nitinol is a material that's been used in cardiac devices for decades. And the company Ivantis has produced this device in order to not only bypass, but in order to scaffold approximately 3 clock hours of the trabecular meshwork, or I'm sorry, of Schlemm's canal. So these are the 2 main companies that are producing the trabecular meshwork bypass and scaffold devices. Moving on to viscodilation. The original viscodilation device was the iTrack catheter, formerly owned by Alex company, but now owned by Nova Eye. And this technique is known as canaloplasty. Originally, canaloplasty was designed to be an ab externo procedure. One of the things that made it difficult for adoption, though, was a very meticulous dissection that was needed in order to access Schlemm's canal ab externo. But as innovation occurred, we now have the ability to perform canaloplasty ab interno, and that is using the iTrack catheter, which you see here. This is using a microcatheter that's attached to a lighted illumination system in order to discover where you are in that space in order to know whether you're going down the regular trabecular or conventional pathway through Schlemm's canal, or if you may have hit some abnormal dysgenic tissue, or maybe you're heading into an aberrant channel such as a collector channel. The Omni device, which I've recently or previously discussed with you, I wanted to mention again that the device is not only used to create an excisional or a non-excisional goniotomy, but it can also be used to viscodilate the canal as well. So the same device can be used for a dual purpose to viscodilate as well as to create a cleavage through the trabecular meshwork. In the future, there'll be a third company known as GLAUCOS that makes the iStent that will create an I-prime device, which will be very similar in order to use viscoelastic to Moving on to our subconjunctival devices, there are two current devices that are currently available in the world, and one is the ZenGel stent, pictured here, which is a 6mm porcine gelatin stent that is used to bypass the conventional flow pathway into the subconjunctival space. Originally, the company designed the ZenGel stent to be delivered as an ab internal technique, but many of us have found even better results or more predictable results with an ab external technique, and even with an open conjunctival ab external technique, augmenting with mitomycin. Next is, in terms of subconjunctival devices, we have the PreserFlow, which is by Santen. And this is using a unique material known as sieves, which is a bioengineered material, in order to create this device that has less tissue reaction. We're excited about this device. There are some long-term studies from our colleagues, Juan Valle in the Dominican Republic, who has a large 4 or 5 year follow-up of a large series of patients who have received the PreserFlow device. The nice thing about the PreserFlow device is it's in the space that we're familiar with, in the subconjunctival space, using an ab external open conjunctival technique augmented with mitomycin in order to deliver this microshunt into the eye. The microshunt has a 70 micron lumen, and similar to the ZenGel stent, which has a 50 micron lumen, based on flow dynamics, by limiting the internal lumen, we're able to actually create some internal resistance to reduce some of the dreaded complications that we all have faced in our careers, such as a significant hypotony and overfiltration after trabeculectomy surgery. Cyclo ablative procedures have now really moved into the mixed space as well, and we have several different ones that I want to categorize. One is the ECP, which is the endoscopic cytophotocoagulation probe. This is the probe that's used through an ab internal technique that allows us to directly visualize the ciliary processes in order to treat them. I've categorized the micropulse cyclophotocoagulation technique also as a mixed procedure because it's extremely gentle on the eye with very little inflammation. It's not the CPC of old where there's significant inflammation. Something new that will come down the pipeline later is the UC3 technique, which is using the principles of ultrasound in order to maybe stimulate cytokine modulation and in order to modulate the trabecular meshwork pathway. It's essentially, we all know that there is some effect to phaco emulsification in terms of IOP lowering. And some of us believe that it may be related simply due to the ultrasound energy. And it may actually create a modulation similar to what we find with laser trabeculoplasty. So this is using a unit that applies circumferential ultrasound energy to the perilimbal region. The final category is suprachoroidal shunts. The CyPass unit was the first one that was FDA approved here in the United States, but unfortunately was withdrawn a few years ago because of concern of endothelial cell compromise. So because of that, the device was taken off the market. iStent Supra was also recently withdrawn from R&D. Not necessarily, it never entered the market here in the United States, but was in clinical trials. And I think because of concerns with CyPass, the company GLAUCOS has decided to withdraw their efforts to bring it to the market. A couple of other devices that may help us in the future with suprachoroidal drainage in a more predictable fashion is the MiniJect and the StarFlow, both by iStar Medical. Here you can see the MiniJect. The MiniJect is a silicone, medical grade silicone shunt that's applied through an ab internal approach into the suprachoroidal space. This is the StarFlow device. In contrast to the mini-eject, the StarFlow device is applied or implanted through an ab externo technique under a scleral flap. While not in the typical category of MIGS, there's something that I want you guys all to understand about the future. We all know that bleb surgery can be difficult to deal with. It has its challenges, as we've mentioned from our prior speaker, that it can be high maintenance. What if there was a way that we could actually filter aqueous without blebs? And this is a potential future option, and it's through transcorneal filtration. This is the Bequin aqueous microshunt that I've shown you on the screen here. And this is a fluidic channel engineered to lower pressure through a transcorneal approach. And this device is applied transcorneal at the limbal region in order to shunt fluid onto the ocular surface. We understand that that inherently sounds dangerous, but the company has designed this in order to create biomaterials, in order to prevent biofilms that develop on the device. And this device has a one-way flow mechanism to prevent microorganisms from re-entering to the eye. But stay tuned, the company is still working on its predictability and making sure that they can bring a device that is safe to the market. I want to just add a little bit about the GATT technique, because I know that many of the devices that I've mentioned in the previous slides are not available in India. So there are some MIGS options that are currently available to you that I know many of you have currently adopted in your practice, and that's the GATT technique. The GATT technique uses a 5-O-proline suture, reusable microforceps, low temp cautery in order to flange the tip of the proline, and allows us to create between 180 degrees or maybe even less, maybe even 90 degrees if you so choose, or up to 360 degrees of treatment. This is a fantastic technique that I think has really brought MIGS surgery to the rest of the world. And I would encourage you, if you have not adopted it already, to consider adding this as maybe one of your first MIGS procedures in your armamentarium. The final technique that I wanted to mention was the bang technique. This was popularized and pioneered by Arsham Shabani from Washington University in St. Louis. And it uses a 25 gauge or 27 gauge needle, which all of us have access to. And you simply take a needle driver or needle holder and bend a 25 gauge or 27 gauge needle. And you use it to create a goniectomy, similar to what we can do with a Cahook dual blade or a trabectome. And this can be used to simply strip away the trabecular meshwork in a similar fashion for an extremely low cost. So consider adding this to your armamentarium as well in order to employ a goniectomy technique that is very low cost. So thank you so much for your time. I'm happy to entertain any questions that you might have about MIGS surgery. But I think one of the parting lessons that I wanted to give about MIGS surgery in general is that MIGS really works best in the early spectrum of the disease. It's not really appropriate for late stage disease or where you need to have very low intraocular pressure. So I encourage all of you to really think of it as an early to mild. You're going to have the best results in the early mild to moderate disease. That, with that being said, I think there are sometimes indications where we feel like there are poor options for traditional glaucoma surgery in our severe patients where this may be our only option. And the other lesson about MIGS is that we are now moving into a space where we're combining MIGS options. So for example, let's say you were to do a goniectomy, maybe combining that with CPC or a cyclo ablative technique may give us more profound results. So I think there's this MIGS space, while we traditionally think it works best in our mild to moderate severe or mild to moderate glaucoma patients, it may be an option for certain severe stage patients. Thank you so much for your time.
Thank you, Dr. Craig, for giving us such an extensive overview. I'll start with some questions. What is the percentage reduction in intraocular pressure do you expect in these procedures? How close to 10/10/10 you get in these cases?
Great question. I think in general, if you were to take all the studies that have been published for MIGS devices, most patients will end up in the mid-teens. Now, one thing that we're finding in our clinical experience is that, for example, placing an iStent, simply putting it anywhere you want in the trabecular or in the canal may give you variable results. But one of the things that we're doing now more routinely is before surgery is looking on the ocular surface, looking for episcleral veins, and looking for any areas that we think may be more promising in order to bypass. During surgery, a few tips in terms of where to apply those stents and devices include looking for areas where we know there could be increased flow, such as extra pigment in an area. That may indicate that those are areas that are flowing. Many of you have done intraoperative gonioscopy and have seen patchy pigmentation. And that's actually a clue to tell you where the flow may be occurring. And so that may allow us to better target our angle-based procedures such as goniectomy or device-based procedures such as the iStent. So around mid-teens in general, but we do find that there are some patients that can achieve close to IOPs and close to 10 with combination techniques. One of the techniques that I like doing is both viscodilation with a stent. So I do ABIC, ab-internal canaloplasty, and then I apply a hydrous microshunt in an area where I think there is the most flow. And I seem to be getting lower results on average into the low teens in some patients if we can catch them early enough.
So then, supposing there has been a case of a trap failure, I don't think after what you said, you would think of doing a mixed procedure in these cases. Would you?
Yes, I think one of the things that we're learning about the eye system and its in aqueous flow and plumbing is that, for example, we've had some patients where you do a trabeculectomy, it seems to work for a period of time, and then because of reasons, because maybe they were a poor candidate for subconjunctival filtration, we've gone back into the angle to do a GAT procedure or a trabectome procedure, and we found that it can work. And I think part of the issue is that when you shunt fluid through the conjunctival space, there may be some modulation to the actual conventional flow pathway. And if we can wake up that pathway later, it may actually be revived and it may actually create some flow. Now, in some cases of severe disease, the distal outflow channel system is atrophic and is going to not yield very poor, or is going to yield very poor results. One of the things that we've been using is a proxy for understanding who may benefit from angle-based procedures is, as you do your visual field test, if the mean deviation is over -12, that might be a proxy for more severe disease that may portend a poor prognosis for angle-based procedures of any kind. This was found in Dr. Devinder Grover's study. As they looked at their long-term results of GAT, they found that patients who had a mean deviation, I believe over -12, really had a lot poorer outcomes and didn't do well for their long-term outcomes.
Murli, you'll ask some questions?
Yeah, Dr. Craig, I have a question for you. That is, in patients, I have a patient with a severe ocular surface disease and severe dry eye, open angle end-stage glaucoma, and pressures of 28 on maximum medical therapy. So he seems to be a poor candidate for trabeculectomy because the dry eye is really severe. Would GAT work in this case? Can it be combined with cyclo G6? Have you combined GAT with cyclo G6 in these patients? Is that an option?
I think so. I think this is a reasonable option for patients who are very poor candidates. You could either decide to do it at the same time or stage the procedure. You could simply start with the angle-based procedure first and see what kind of results you get. And most of the time when we're doing angle-based procedures, we're typically operating in the nasal angle. But don't be afraid to come across the eye and look in the temporal angle. You may find better, healthier tissue, or you may find clues in the angle to give you some indication of where to actually do your angle-based procedure. Or you could do it simultaneously. So I think a staged approach or a combined approach simultaneously of combining those two techniques could work for your patient.
I have a question both for Dr. Craig and Dr. Tanuj. How would you choose glaucoma patients for a premium IOL surgery? Your thoughts individually in different parts of the countries?
Yes, so great question about phacoemulsification and premium IOLs or just cataract surgery for glaucoma patients. I will give you my general bias. While lens technology is improving in terms of presbyopic options that we have for patients, I think most of our current technologies that we have for IOLs do reduce contrast. In my opinion, reducing contrast in a patient who already has a disease that reduces contrast is not ideal. And so I tend to really avoid using premium IOLs in glaucoma patients, except for very extenuating circumstances for patients with extremely mild disease that have pre-parametric disease where their visual field is full. I may consider using an extended depth of field lens. We have some new lenses that will be non-diffractive techniques that may actually prove to be helpful for patients who have glaucoma. So this is a new space, but I think in general, my general party line is that I don't use any type of diffractive technique or extended depth of field lenses in my glaucoma patients. With that being said, I think toric lenses is something that's definitely available should be available to all of our glaucoma patients. And in the future, we will have some non-diffractive presbyopic options that may allow us to use premium IOLs in our glaucoma patients. One technique that I use often is actually just a little bit of mini monovision to extend the depth for patients to give them more working distance. And I think that's an appropriate technique as well as to use monovision.
Dr. Tanuj?
So I think I'll agree with Craig. The only difference is once you have primary angle closure with ocular hypertension and you're doing an early lens extraction, so there maybe you could use multifocal lenses because there is no retinal nerve fiber layer damage. So that is one subgroup when you're doing an early lens extraction, primary angle closure, not primary angle closure glaucoma. So otherwise, I think once you get an RNFL defect or a visual field defect, you should only use a monofocal IOL. And one quick question to Dr. Craig, have you had late onset spontaneous hyphema after GAT?
Well, yes, it's a great question. And I think one of the things that we're trying to learn exactly what happens and why these patients may develop late onset hyphemas. I really encourage patients to be very careful about Valsalva as well as their activities. We have found that some patients have laid on that particular side. If they sleep on one side more, they may have more prominent hyphemas on that side. But typically the settings where we're seeing late onset hyphemas is in patients who are doing some either breath holding or even doing yoga with a down head position for prolonged periods. Those are occasions when we're seeing prolonged hyphemas. They tend to be very transient and self-limiting. And as long as these happen, the hyphemas happen because you are not able to, you have increased episcleral venous pressure that causes retrograde flow of blood. And so it can be disconcerting for patients, but fortunately it's self-limiting. Now, one of I think the things that really is discouraging for early MIGS adopters in the GAT space, for example, is having the early onset hyphemas actually, prolonged and pronounced hyphemas post-surgery. So a few techniques that may help you in your GAT hyphema rate is one, we leave viscoelastic inside the eye at the end of surgery to help prevent rapid decompression. Maybe about 30 to 40% fill with a cohesive viscoelastic may help to prevent that rapid decompression. Number two, immediately after the surgery, you should try to put the patient in reverse Trendelenburg position. Try to get the feet down immediately, get the head up high so the patient is not lying supine for too long, which may also promote hyphemas. And I think those things have really improved our hyphema rate and made it so that we're seeing a lot less. Also take some time after the trabeculotomy has been completed, or if you decide to do 180 degrees or 360, is to use your BSS solution, your balanced salt solution or lactated ringers, and to really spend some time flushing and irrigating the entire eye. And that helps to push blood down further the distal outflow channel and prevent that blood from quickly coming into the anterior chamber.
Thank you.
Thank you. Thank you very much, Dr. Craig. Stay with us till the end of the meeting with your inputs. Thanks a lot.